Hi, I'm Margie. I'm the stroke program coordinator here at Arnett, and I am here with Missy to do a little video for you so that you can have a little more time to think about how to mix TPA. We understand that it's not something you get to do very often, and sometimes it's stressful when you're trying to give it. So we wanted to give you an opportunity to have something to watch and also some practice tools to work with when you have a slow moment, as if that ever happens in the ED, but anyway, just in case. So first thing we're going to do, the TPA comes in a box like this and it's kept in your Pyxis. Now in the regular hospital, the pharmacy has to send it to wherever the stroke is, but in your area you have one of your own. Once a doctor decides that the patient's probably going to be a candidate for a TPA, there is this little checklist of things that we need to think about. And we can help with this to determine whether they truly are a candidate or not. Some of the things that are important to us as nurses to keep an eye on are what's their blood sugar, because if their blood sugar is low, obviously that's one of the stroke mimics sometimes. But also, what are their platelets? If the platelets are less than 100,000, they need to really think about whether they want to give TPA to this patient or not. And then we always do a PT INR, and one of the things we're looking for is an INR that's 1.7 or greater, because if it's that high, we should not give TPA. The thing is, we don't really have to wait for those results unless they're already on Coumadin, or unless we have an idea that they're going to have trouble with their INR. Sometimes, alcoholics or people with hepatitis or cirrhosis will have problems with their INR even though they're not on that medication. So that's something to think about. Then any type of bleeding that's in a non-compressible site. So of course, bleeding in their head, whether it's subdural or intracranial, it's not a good thing for TPA to be given. Major surgery in the last couple weeks. And on any of those new anticoagulants, if they've taken it within the last 48 hours, they're already not a candidate for this drug. So that's what this sheet is all about. The doctor does need to chart that stuff. They are working on getting something similar to that in Cerner, has the same questions. That's one of the things that the whole system is working on as a RIE. Next, we want to talk about how to calculate the dose. Now remember, blood pressure is important. We don't start TPA on anybody whose blood pressure is higher than 185 over 110. We can use drugs to get it down. Be careful about that. You want to get it down gently, not bottom them out, because hypoperfusion to the brain is really bad during this time. And then we're going to calculate the dose using this. So this sheet is there for nurses. Obviously, the pharmacist calculate it too, and it's a double check. But this one will really help you in how to program your pump when it's time. So Missy and I chose a patient that weighs 100 kilograms because it's easy math. But also to illustrate this one thing, if you have a 100 kilogram patient, the dose is 0.9 kilograms, 0.9 mils per kilogram, and you'll see that turns out to be 90 for this patient. 90, however, is the highest dose we ever give anybody. So if you have a patient that weighs 450 pounds, they're still only going to get 90.